Hello, and welcome to our session today on long-term care financing and delivery. My name is Nora Super, and I'm the Senior Director of the Milken Institute's Center for the Future of Aging. Now, I'd like to share a few statistics to help frame the issue. Long-term care is a pressing issue, particularly in rapidly aging populations such as the United States. 70% of adults aged 65 and older will require long-term care at some point in their lives. More than half will experience a high level of care need, defined as assistance with 2 or more activities of daily living, such as eating, bathing, or dressing, for at least 90 days, or those who have a severe cognitive impairment. The cost of formal long-term care services are staggering. In 2019, the price of a nursing home stay averaged about $102,000 a year, or well over 2 times an older middle-class family's income. Today, pensions aren't available to most Americans, and very few have saved sufficiently for retirement. A typical American with savings and home equity, age 65 to 74, has median financial assets of under $110,000 and only $87,000 in home equity. Most Americans are unaware that Medicare does not cover long-term services and supports, and therefore have not adequately assessed care cost, insurance options, and the income asset limits associated with qualifying for Medicaid. On average, an American turning 65 today will incur $138,000 in future long-term care costs. Yet, over the last 2 decades, the private long-term care insurance market has changed considerably, contracting from over 100 insurers offering long-term care insurance coverage in 2004 to roughly a dozen today. The COVID-19 pandemic has brought into sharp focus the country's urgent need for improved access to care and appropriate funding mechanisms. Staff members and seniors living in nursing homes and long-term care facilities across the U.S. account for more than 50,000 coronavirus deaths, or more than 40% of the U.S. official death toll of 116,000, according to analysis from the Wall Street Journal. As the Senior Director of the Milken Institute's Center for the Future of Aging, we've been particularly concerned that the risk of serious illness from COVID increases dramatically by age. The highest number of coronavirus-related deaths since February have come among people aged 85 and older. The second highest has come among people aged 75 to 85. These sobering statistics demand that, as a nation, we rethink the way services are financed and delivered to some of our oldest citizens. To address long-term care funding and delivery challenge, the Milken Institute's Center for the Future of Aging and innovative finance teams joined together to conduct market research related to long-term care funding and delivery models over the second half of 2019. Through our research and outreach, we have identified a menu of potential solutions to address the related long-term care funding gaps, market failures, and care delivery needs. We have a terrific lineup of speakers to help us discuss the lessons learned during COVID-19 and potential solutions to better finance and deliver long-term care in the future. You can find each of the speakers' complete bios on our website. Jeff Huber is President and CEO of Home Instead Senior Care, the leading global provider of home care services for older adults committed to addressing the challenges of the aging global population by promoting consumer choice and care. Bob Morse is Executive Chairman of Bridge Investment Group, a leading real estate private equity firm and owner-operator focused on select U.S. real estate verticals, including senior housing and affordable housing. Tom McInerney is President and CEO of Genworth Financial, one of the largest long-term care insurance providers in the U.S., with over 1 million people covered. Good afternoon, gentlemen. Thank you for being with us today. I'd like to start with one question for each of you to respond. And why don't we start with Jeff, since Home Instead is really on the front lines of providing services and supports to older adults at risk of COVID. Jeff, can you tell us how COVID-19 has changed the way you do business? Can you discuss some of the lessons you've learned?
Sure. Thank you, Nora. It's a pleasure to be with you on such a distinguished panel. So I appreciate your being here. So just 20 seconds on Home Instead. We are the leading provider of in-home care for seniors. We're in our 26th year. Today, we have about 95,000 clients on any given day. We have operations in 15 countries, about 1,150 businesses. This year, we'll provide about 90 million hours of care, and about 2/3 of our clients have Alzheimer's or some other form of dementia. So you're right, we really are on the front lines and caring for a very vulnerable population at home. So, it was a very consistent story for us across our international markets, with a couple of notable exceptions. What was similar was a sudden decrease in our client base. So here in North America, for example, in the first 2 weeks of March, we actually had high watermarks consecutively for number of clients served per week, number of hours served per week. Overnight, the third week of March, 25% of our client base evaporated, went away. They paused services. Those were mostly lower acuity clients, fairly independent. Some might have had family members who were able to come in and care for them since they were now working from home. Really similar across all of our markets. On average, each one of our markets had a reduction of about 18 to 30% of their client base within the time frame of about a week. A couple of notable exceptions: Australia wasn't really hit. Netherlands was not really affected at all in terms of the client base. China, however, 100% of their client base evaporated. So we were really shut out completely from the home care market for better part of 4 months in China. But on the other hand, we saw an increase in the hours of higher acuity clients, actually increasing hours. We saw an influx of clients coming out of hospitals so that hospitals could increase capacity, make room for COVID patients, and to get people out of a clinical setting. We saw an influx in clients coming out of nursing homes and facilities, families wanting to care for them at home. And all of those tend to be higher acuity clients. In all markets, we saw a sudden increase in demand for and use of PPE. So we were able to set up supply chains, fortunately, and deploy those to the hotspots. Across the board, we saw great collaboration with local health officials, and we were able to be deemed essential in every market. And so everywhere we were able to go into facilities where we often serve clients, often ahead of times of family members. We could go in, but families couldn't, with one exception, and that's Canada. And we've been shut out of facility work in Canada. We still are. Just quickly, in terms of recovery across the board, we're getting back to pre-COVID levels. Here in the United States, for example, inquiries for new services are at pre-COVID levels. Our number of hours last week was at nearly 97% of that high water mark we hit back in early March. So the number of clients is rebounding nicely. But in terms of what's different, we've seen a surge in the adoption of virtual capabilities for the last couple of years, as so many companies are. We've been in the midst of our own digital transformation. We've been rolling out a number of new systems and virtual capabilities. Two, just I'll touch on briefly. The first is a learning management system. So we were able to deploy relevant and timely training to our caregiver workforce. For example, we could instantly deploy the hand hygiene curriculum to our caregivers and do so remotely without having to bring them in for training. And that was important because early on, I asked that 100% of our caregivers be retrained in that curriculum. And then secondly, we saw a major uptick in the adoption of our home care tablet. A couple years ago, we entered into a partnership with GrandPad. This does many different things for us, but one of the key things it does for us is to allow unnecessary bodies going into and out of homes through virtual capabilities. And it provides a virtual connection between the client, the professional caregiver, the family caregiver, and our office. And so we've been able to conduct quality assurance visits remotely. We can do introductions of new clients and caregivers remotely. We can have virtual eyes in the home to look at a situation without a nurse having to go out and evaluate that in person, and we can escalate or deal with it remotely. So our franchise offices that had adopted these technologies before the crisis were very, very glad that they had begun their transformation, and they really accelerated it. And we saw a big increase in interest from our other franchise owners in adoption. So COVID has really acted as an accelerant for our transformation efforts.
Great, thanks, Jeff. Bob, in the senior housing sector, fear has mounted over declining occupancy rates as COVID disproportionately impacts people living in nursing homes and assisted living facilities. What lessons should the industry take from this experience to become more resilient faced with future public health crises? And could you talk a little bit about the difference between some of these privately operated facilities and publicly operated senior care facilities in the market?
Thanks, Nora. That's a really interesting question. And again, thanks for including Bridge on this panel and me and to my distinguished fellow panelists. It's interesting because I think caring for the fragile elderly residents of our facilities and for seniors care in general is a significant responsibility and sometimes can be a burden, but many people in the industry feel that it's a privilege in a lot of respects. We entered the COVID crisis with a number of protocols that were designed to ensure the safety and health of our residents. They came about in part as a reflection of the fact that there's an influenza season every year, and influenza can be particularly dangerous for elderly, fragile residents. We amplified those protocols pretty dramatically at the time that COVID reared its head. We increased sanitization, we restricted visits, we tested our caregivers, and I think at least as a privately managed group of facilities, we manage about 11,000 units at this point with slightly more residents than that. We were able to contain very dramatically the spread of COVID. About 1.5% of our residents were impacted by COVID. We lost some residents as any group of 11,000 would experience. Yesterday was a watershed day. We resolved finally the last open case of COVID. Some folks are still in the recovery phase, but the fact that we restricted access to the facilities, we moved to virtual touring for all new residents. We, for a long period of time, had insulated people by delivering meals to rooms, et cetera, proved to be very effective. I think that there's a misconception, which is understandable when you read the paper and your statistics about fatalities in nursing homes in particular. We, by the way, don't manage skilled nursing facilities, more independent living, assisted living, and memory care. Typically, those publicly operated facilities don't have the staffing. They don't have the standards of care. They don't have the protocols that the privately managed facilities do. And you know, as we know, COVID can spread like wildfire in overcrowded facilities. And we've worked hard to avoid that fate. You mentioned a couple of things in your introduction about cost of managed care, and about the increasing need for managed care, because we do live in an aging society. We call it the silver tsunami. As particularly baby boomers reach the age of 75, the either appeal of or necessity of managed care becomes more urgent. And one thing that we are proud of is that we can and others in the industry on a continuum, and home health care is definitely part of that continuum, but for some people, managed care is either a choice or a necessity. We can offer those services, maybe not to everybody, but certainly to the mass affluent and perhaps even more of the population. The combination of Social Security for people who receive Social Security, a spend down of home equity or other assets, sometimes some contribution from loved ones or other responsible parties makes, in our view, the types of services that we offer affordable. And we have a financial counseling program where before anybody comes into a facility, we help them understand what the cost would be and how affordable they are. The flip side of that, which is something that we're passionate about, is the managed care industry employs a lot of people. I think for many years it's been the largest and fastest growing employer of professionals across many industries. And there's an endemic, we think, undercompensation for the people who do really hard and really important work of caring for our loved elders. And at Bridge, we've embarked on a program where we're raising minimum wages. We're making sure that people have a living minimum wage. We're recognizing that, in effect, you get what you pay for. And if you expect high quality care, you need to pay for that high quality care. I think that's very important for the industry in general. And that coupled with affordability of the services goes to the critical need to have efficient and effective operations. We think at the scale we're at, we are able to aggregate our procurement. We're able to professionalize the approach that we take in our individual facilities, and it accrues all really to the benefit of our residents. But it's a really important sector of the economy. There has been a lot of new capacity coming into the industry. Having said that, I think in general the industry is about 86 or 87% occupied. There's a pretty big distinction between the average facility and the well-run facility. And candidly, when you walk into a facility, you can tell right away which is average and which is well-run. Like it or not, a lot of our residents, as they've gotten older, have gotten much more candid in their views. And so, if we don't run a good facility, and somebody's coming in either digitally or in person to review the facility, our residents will let them know what their experience is. And we are proud of the satisfaction that we create in our resident bases. So I view capacity or supply as secondary really to the objective of creating a really satisfying, high quality, enriched part of the later years of life for our residents.
Great, and let me get Tom into this conversation, because I know, Tom, you've been worrying about and thinking about these issues for a long time. We've all known the baby boom generation is coming, and we've predicted this for a long time, but it seems like maybe a turning point with COVID, that people are really recognizing the urgent need for long-term care. And as both Jeff and Bob mentioned, affordability is a huge issue for middle-class Americans, for those that don't have access to Medicaid benefits or don't have enough money to self-fund their care. Tell us a little bit about Genworth, where you've been in the private long-term care insurance industry, and things that you might see that are accelerating due to COVID.
Well, thank you, Nora, and it's great to be with you again. The last time I saw you was at the White House when you were running the National Conference on Aging under President Obama. And I also want to thank Jeff and Bob for being on the panel. We work with their firms and they do a great job. And finally, I think the Milken Institute and your summer series is great. And I do think you're one of the experts in the world on aging and all these issues. It's been a very big challenge on the insurance funding side for insurance. Our predecessor company that sold life insurance started in 1871. So you wouldn't be surprised to know that long-term care, it's 40 years old. But compared to other lines of insurance where we had much more claim data and a lot more statistics, when we all started as insurers, and you mentioned in your earlier remarks that there were 100, there's now about a dozen. And what happened is, without any claim experience, any data, any real views as to what would happen, we all started around 1980. I think in our case, the first policy that was issued was in 1974, without any understanding. The actuaries for our company and all 100 companies made the best decisions at the time. They proved to be very wrong. For a lot of different reasons, I don't want to go into. It's well recognized, but just a couple examples. You mentioned $102,000 a year for costs in one of the facilities that Bob talked about, one of the better facilities. Women in particular, who tend to have a higher propensity to have Alzheimer's or severe dementia diseases. We have many cases of women being on claim for 7 years or more, so at $100,000 a year, and obviously those severe dementia cases require pretty much 24/7 365, while a lot of the claims start, in Jeff's side in home care. Usually the complex, the more significant challenges on those severe dementia cases end up in facilities that Bob and his organization run. And so it's been a big challenge. And I do think that 55-60% of our claim costs over time have gone to the severe dementia type claims. I've said we've been in the business for, we're the leader in long-term care insurance. And we paid almost 300,000 claims over those 4 years, and almost actually a little more than 20 billion as the end of last year in claims. So we now have a lot more information, and we know that while you're right, the average claim is 138,000. Another statistic is, PwC did this study in 2018, that except for 25% of the cases, and those are usually the severe dementia cases, 250,000 is what a family will pay, whether it's through insurance or out of pocket, what have you. And so I do think where we're trying to go is, if you look at the older policies that provided unlimited number of years of coverage under HIPAA regulations that were in place for a long time, you had to have 5% compound inflation protections, at least offer that. And so these policies had huge total benefit pools. And it's really those benefit pools that drove a lot of losses for companies. On our legacy policy, we call it, all the policies issued from about 1980 to about 2005, we lost $3.6 billion cumulatively. And so I think the direction going forward is to have more capitation, so lingo for less total coverage. And I think having a policy that with inflation protection would cover you in today's dollars for about $250,000 would be much less expensive than the old policies. I think you need some inflation protection, but 5% adds a huge cost. And I do think that for the claims that go above 250,000, and that's 75% of the claims are 250,000 or less, 25% more. I really think there needs to be some public insurance program that covers that. Now, as you mentioned earlier, Medicaid and Medicare, or maybe Bob and Jeff mentioned those, Medicare doesn't really provide custodial care. It does provide the medical care after an operation, but only for about 90 days. And then people are on their own if they have insurance, and very few really have insurance. Medicaid is the payer of last resort. I think most middle class, you talked about the middle class, they don't want to end up on Medicaid. So I think whether it's through insurance, whether it's a traditional policy, a hybrid policy that combines life insurance and long-term care coverage, there are a lot of innovation there. But or whether you're just saving in a 401k plan or an IRA or what have you. So you need around 250,000 of coverage, however you get it. And that will cover you 3 out of 4, but 1 out of 4, and those are usually the Alzheimer's, severe dementia. It's going to be a lot more expensive. And we've paid claims in the 700,000 to $1 million or more range. And that's where I think, whether it's the federal government, some states we may want to talk about this, have programs. But for the very expensive claims, if you're really wealthy, you can self-insure. If you're reasonably well off, say mass affluent, you can afford, it's expensive these days, over $10,000 a year for a big policy. But we're trying to get the policies down to $1,500 to $2,000. And by having a lower amounts of coverage, a more modest inflation protection, and then some coverage from probably a public entity, a social program. I know the Milken Institute and you are working on a lot of those. It's probably going to have to help families, particularly the middle-class families, if they are the unlucky ones that ends up with these severe disabilities that are mostly tied to severe dementia.
Yeah, I mean, as you probably know, Nick, that represents senior housing market, put out a study, about the lost middle. And I think that the middle income folks are the ones who really don't have that protection. We have the protection for our lowest income citizens, and then as you mentioned there, so you put a lot of great ideas. We are hearing, as you remember, under the Obama administration, we tried a public program that got repealed because many, it was voluntary, which was one of the biggest challenges with it because of the affordability issue, which becomes one of the challenges with designing the insurance. I've been encouraged by what some states are looking at, experimenting with, trying to do that. Jeff, you mentioned some innovations that you all are using. In our study, we also found technology solutions were raised by we interviewed over 50 experts about what they saw. And I think that the most promising thing is, first, when you talk to people about long-term care, they say, oh my God, the system's broke, we just got to blow it up and start over. But when you push a little bit and say, well, what can we do that can make it more efficient, more cost-effective, better quality? And we came up with a lot of different suggestions for that. One of the top ones were some technology solutions. And Jeff, you mentioned some of the things that you all are doing. I think COVID has also given us an opportunity to think so much more about technology as a solution to deliver care more effectively and efficiently. The telehealth services, of course, from March to April 2020 alone, Medicare beneficiaries increased their use of telehealth services by 120-fold, from 11,000 to 1.3 million. So do you think this trend will continue, where people that sometimes some of the problems happen in nursing home and home care, in the transitions from home to the hospital, going into the hospital, people get sick, they get infections, et cetera. How much, are you thinking about these technology changes that we're witnessing that might affect the business in the future? Question for all of you.
We certainly see technology playing a significant role in the delivery of care moving forward. We do not envision a world where it replaces care. We're really talking about the intersection or the partnership between high tech and high touch. So, we're a very, very high touch company. On average, we're in our clients' homes about 26 hours per week. But we saw, just as everybody's alluded to, what's coming down the pike from a global aging standpoint, and knew that we just needed to increase capacity to care. The system needs more capacity. Technology should be an enabler to allow us to do more with less. We also have seen, what's happened in so many other industries where the digitalization has really disrupted their business model. We wanted to get ahead of the curve with that. So years ago, we began making significant investments, really first and foremost, and just creating some of the underpinnings, some very non-sexy things in terms of technology, not bells and whistles, but plumbing. I've learned more about single sign-on than I ever cared to know about, but those are the kinds of things that enable scale to happen. And now we're at a point where those things are in place, and we're really starting to roll out new systems that allow us to do more with less. I mentioned one of our partnerships, GrandPad. That's a hardware, but it's in the home. It allows us to have interactions. It allows us to have virtual capabilities, but it's increasing the capacity of a local office. So one of our, what we call key players, administrative staff, part of the care team, one of the key functions they do is to do quality assurance visits. And, up until now, that's been done, in person in the home. That has inherent constraints. Now that one person can, where they might do 2 or 3 or 4 in a day, now they can do 15 in a day. And not only can they do more, but they can increase the frequency of those quality assurance visits, and they can do them with great quality, equal quality. And because they're doing more of them, the overall quality is going up. So that one person now has increased capacity. So absolutely, not a replacement, but a supplementation, enhancement, and enabler of higher quality, more efficient care.
Yeah, that's great. I've definitely seen some instances and pilot studies where some of the people receiving care prefer the technology solutions because they can control the environment that they're engaging with the caregiver. They can have someone who speaks their language that's there. There's some of the benefits of telehealth that really can improve the care experience. I'm thinking, Bob, in the senior living industry, because of the increased risk of COVID, many people have been isolated from their family members, from not able to go see their doctors. How has that changed the way you all are thinking about technology in residence?
Connectivity is really important, and it becomes even more important, we think, as you age, to have the spirit of companionship in a lot of respects. We've We have had to insulate many of our communities during the COVID pandemic. Having said that, we've had been implementing and have continued to implement a number of technologies that create connectivity. We have internet-based applications that allow families and community members to talk to each other on an ongoing basis. We can send out alerts to responsible parties, to family members that detail the interactions that our team has had with their loved one on an as frequent basis as desired by both parties, keeping privacy concerns obviously closely in touch, and have increased connectivity in a lot of other ways as well. Telemedicine, you mentioned some statistics about telemedicine. Another way to think about it is that apparently in May, any one day in May of 2020, there were more telemedicine visits than in all of 2019 as a year. And many people have had really successful and productive visits with their physicians or other medical providers during those telemedicine appointments. So I think that that's a trend that's going to continue in a lot of respects. One of the other challenges and opportunities is to manage the degree of centralization of care. One of the benefits, there are some costs to having 120 or 100 or 200 units altogether. There are some benefits in terms of delivering really high quality care in a cost-effective way. I made a note to myself, it would be great to spend some time with Jeff and work to understand what the relevant costs and break-evens are between how we provide care and, Jeff, how you provide care. And I suspect at some level of acuity, there's a crossover at some point. We're all working to reduce costs, to make care most affordable. Some of the work that we've done would show that, at least relative to traditional, hire somebody for 8 hours a day, or if there's particular acuity, 16 hours a day or whatever, care at home is dramatically more costly than it is to be a resident in a managed care facility. And of course, there are some break-evens and trade-offs there, but the overall goal of providing an appropriate level of care at an affordable cost for everybody, whether it be for the mass affluent, whether it be for the less affluent, or whomever, is really important. And technology plays a big factor in terms of allowing us and others to deliver that care on a cost-effective basis. If we can have, one physician.
And one thing we haven't. Oh, go ahead.
I was just going to say, if we can have one physician who can split time, her or his time, between two facilities as opposed to one facility, it's a pretty significant cost savings, and without necessarily a diminution of care at all.
Tom, I think, we, in some of our research, we've said that long-term care and life insurance industry is a little behind health insurers in terms of predictive modeling, thinking about remote monitoring, ways to intervene before there's a high risk claim. Some of these use data analytics to do that. How much do you see that as a future in the long-term care insurance industry?
Nora, I agree with you, and I think that's a very fair criticism of the industry. And I also agree with much of what Bob and Jeff had to say. One thing I would like to do, take us back to COVID-19 and some of these issues with equality and racial injustice. I think if there's a silver lining in those, as awful as both of those situations are, I think we've learned a lot that for COVID, if you're older, you have a less mature immune system. But beyond that, if you have a pre-existing condition, you're much more likely to be negatively affected. Just like with long-term care and the disabilities, again, while there are, you have Alzheimer's and strokes and cardiovascular disease, and falls are a big part of it. But if you look at the research you've done at Milken Institute, the Alzheimer's Association, and others, there is a correlation, no question, in terms of wellness and technology and using technology to, as you said, to do more in the managed care area with long-term care. You know, I've been in the insurance industry for 42 years, and I spent a lot of time in different lines of business, including health insurance. And health insurance really had, you know, started with indemnity reimbursement and has moved through PPO networks to point of service to HMOs, and now it's you know, it's kind of broad managed care, and that really hasn't happened in long-term care. Long-term care, if you look at how we pay, we're still paying on an indemnity or reimbursement basis, and not really trying to manage the care. So I do think there's a lot of opportunities to do that. But I also think in using technology to live healthier lives. So if you want to talk about any disease, but certainly the diseases that you can get later in life to make you need to either have Jeff's team come in and care for you at the home, or Bob and some of his facilities, it's underlying diseases like diabetes, like obesity, high blood pressure, cardiovascular disease, mental agility. You know, as people get older, they have less social lives. Their brains are, you know, used a little bit less, particularly if they're isolated. So all those things that can be enhanced by technology, just monitoring the devices to do the social interactions using technology. I think all of that will create, as Americans age, or as these baby boomers age, a better environment. So they'll be healthier if they do things to decrease the diabetes issues that they have, or their weight, or lower their blood pressure. Those things all help. There's still just the fact that you're aging. You know, what we find is, you know, a lot of policyholders, when they take out a policy, they're 55 to 60, but the peak claim years are in the early to mid 80s. And so you are going to get those kinds of diseases just because you're aging, and people will live longer and longer, and that will continue. So you can't prolong it forever. But I do think if your underlying health is better, and I think that's where technology can be used, then you can, you know, have part-time care in the home for longer. I mean, eventually you're going to need to go into a facility, you know, near, you know, as you really get near, you know, the end of your disability. So I'm a big believer.
Some of our data
enormous
set
opportunity.
shows, especially with the dementia patients, it's because the caregivers are just so exhausted. And so there are some efforts, I think, to also recognize, if we provide them more support along the way, that won't, you know, people won't feel the need to have to put people in institutions that are less desirable, like we were talking about earlier. You know, before we go to the audience, and I want to remind the audience to please submit your questions through the Q&A so we can answer your questions. You know, Tom, you touched on something that has been really prevalent in our discussions on COVID, and more recently in our nation, with much more awareness of racial inequality and health disparities. According to a Brookings Institute analysis, in every age category, Black people are dying from COVID at roughly the same rate as white people, more than a decade older. Age-specific death rates for Hispanic, Latino people fall in between. And these disparities are observed at all ages, but they're especially marked in younger age groups. You mentioned some of these underlying health conditions that contribute to these. We do a lot of work on dementia and brain health, and really see that connection between not only cardiovascular disease and your risk for stroke, but you can actually reduce your risk for dementia if you practice some of these healthy behaviors. What are, here I am talking to three white guys who are CEOs, which is, in our country is really more common than not. But I think all of us through the past several weeks have really a much more raised awareness of some of these fundamental inequalities and inequities between especially African Americans and Hispanics, who also have a much higher rate and risk of dementia and than white people. What are some things that your company has been doing for all of you to sort of respond to this growing awareness of these disparities?
And maybe I'll start. First, I totally agree with what you just said, Nora. You know, for quality of life, living a healthier life, and ultimately having either a lower chance of having these chronic disabilities later in life or less severe, how you take care of yourself over your whole lifetime is important, and your access to quality medical care your whole lifetime is important. And so I think for Black Americans, for Hispanics, for lower income, for many women who are the only parent for young people, being taught about all of these things and how about living a healthier life and watching what you eat, not doing junk food, getting exercise, being worried if you're overweight because that can lead to diabetes, blood pressure, cancer, all those diseases. And I do think we have to find a way to devote more resources and education to allow Blacks, other advantaged minorities to have access to better health care for their whole life, and to try to educate them on the advantages of all this. One of the things that we're doing is we've done that all our Genworth's been doing that for a long time. We're trying to really step up. We are doing a lot more, both in financial contributions as well as having our 3,000 US-based employees who are focused on these kinds of businesses to work on programs to help serve these underserved communities. I do think that state and the federal government and Americans who can afford it need to provide more support, more financial support. One of the things that I'm very proud about is in Virginia, working with a new not-for-profit. A lot of the people who've been laid off because of COVID-19 are Blacks and Hispanics and people that don't have four-year college degrees. And so we're working in Virginia. We're about to embark on a process to continue work with community colleges to offer associate degrees, certifications, and particularly for the relevance of all four of us, to develop career tracks in caregiving so that you could really make it a profession. I think both Bob and Jeff and we are looking at trying to increase the minimum pay. I think that is a problem for caregivers. It's extremely hard work, as you mentioned, Nora, and they don't get paid very much. So I think we have to allow training. They may not have the desire or at this point in their lives the capacity to go back to a four-year program, but to get some certifications, training to become health caregivers, providers, to make those jobs be viewed as very important, high-level for-purpose jobs, which I think people are understanding that because of COVID. I think there's a lot of opportunity there. So it's one of the areas where specifically we want to do something tangible to help Black and other minority employment, and particularly in fields where, given their level of education, with some further shorter, not a four-year, but a year or part of a year or 2 years to get these skills. And I think there's a lot of opportunity to work for companies, including for Jeff's company, for Bob, for Genworth. And so those are things that we're really focused on right now.
That's great. And I do want to point out, as a woman and as a person who's been focused really on some of the gender differences in these aging statistics, you mentioned, Tom, the older woman that runs out of her assets and has really high claims. One of the things, in addition to all the things about eating healthy and taking better care of ourselves, it's for these caregivers, many of them women, who need to really prioritize self-care as that, in terms of giving people more supports for that, recognizing that it really does, women tend to take on the role of caring for their spouse, and that affects their own brain health, their own stress levels, their own income that they're able to earn over time, which then affects them as they age. So I just wanted to raise that issue. I know, Bob, you mentioned that you all have made a commitment to raise employees' wages to $15 an hour. Do you want to say a few more things you're doing in this area around racial disparities?
Well, I think what I'd like to add is first of all, you raise a very important topic, and it's thankfully something that is a central part of the national conscience at this point. And so change comes, from two directions. It comes from the societal level on the one hand, and it comes from the individual or corporate level on the other hand. And I think we're thankfully beginning to see change being fomented from both sides at this point. Bridge is a people-oriented business. If we don't attract the best and the brightest, if we don't have a robust diversity and inclusion program, if we don't strictly follow our conscience as it relates to ESG policies, we're just not going to succeed. There's the way to achieve our view, and it's embodied in our mission and core values, is the way to achieve excellence is by having multiple viewpoints that are only created through diversity and inclusion of people from all walks of life, sexes, genders, ethnicities, sexual orientation, et cetera. And that's been a central part of our recruiting and hiring and training and mentoring practices for quite some time at this point. I think that actions, often speak much louder than words, and we do try to lead by example. There are many things that the more privileged in society take for granted. We've delivered during the last couple of months, we've delivered about 30,000 meals to many of our workforce and affordable housing residents who suffer from food insecurity. Schools are closed. Kids were relying on free school lunches for some of their nutrition. That went away. We've delivered 30,000 meals and taken that stress off what is already a stressful life. We provided some grants of GP capital to about 7,500 of our workforce and affordable residents, just to allow them to have some extra money to get through the daily necessities of life, which so many people take for granted. And so it's really important to lead by example. I think in a lot of respects, we in our personnel planning, in our succession planning, we have a deep commitment. We've been advised by, amongst others, the Ford Foundation, who invest with us, of how to manage the diversity and inclusion elements of that. And we're learning as we go along, but it's a central part of our DNA at this point.
Great. I'm getting a note. We're like 10 minutes to closing, so I want to get to some audience questions. I know, Jeff, you have a lot to say on this, and one, I know you would be able to address this question that came in about, because I know Home Instead has focused a lot on professionalizing the caregiver workforce. What public policies would you like to see adopted to address the nation's severe shortage of caregivers? What are some things that we could do at the government or state level that could really improve the situation?
Well, a couple things come to mind. I think first is just a recognition that home care is healthcare. I think we've seen through the recent COVID crisis that we play an incredibly important role in the overall healthcare delivery system. We can increase capacity. So just recognizing that home care is an equal partner in the overall healthcare delivery system, I think would go a long way towards professionalizing the industry. I think it's also, there's a lot talked about the disruption of industries and displacement of workers. I think home care would be a fantastic destination. We can give them people who are being displaced out of other industries, we can give them job training, turn them into fantastic caregivers, give them a really great, meaningful and purposeful job, give them a career path. We have caregivers now who've kind of gone from being a caregiver to working in the administrative office of a Home Instead franchise office to become a general manager. And now we have several who are franchise owners. And so I think just incentivizing home care is a great destination in an economy that's really in transformation.
Great, thanks. And we've got a couple questions about the role of Medicare in this. I know, we talked about in our program, in our study about, Medicare is starting to cover some non-medical benefits that might traditionally be seen as home and community-based benefits, recognizing these social determinants of health that impact the overall cost. Tom, I'm just, for you maybe to think about, have you thought about integrating with Medicare Advantage plans, for example, different ways that we might, any of you to talk about this integration of health and long-term care services in a way that would be more affordable and deliver better quality for many people.
Absolutely, and I think Bob and Jeff would agree that there has been this separation of medical care, acute care, with more of the chronic custodial care, and I think having those work together, it will lead to better outcomes. It will lead to higher quality. It will probably reduce costs because you're managing both sides, and so I think there's a lot of opportunities. I would say ultimately, there's the Class Act, as you mentioned, under the Obama that was proposed. It made progress. It ultimately was not passed. And there have been in this election, particularly on the Democratic side, a lot of discussion about expanding coverage. And I believe that at least 50%, and your statistics, Nora, would support it. If the average savings is $110,000, at least 50% of people aren't going to have the personal resources to cover much of those expenses. And I think whether it's Medicare or Medicaid or a new program, we got to really focus on that, because just because of, and we're talking about a lot of baby boomers who are already now in their 50s or 60s, they don't have a chance to redo that. And so I think we're going to have to provide that. My hope is for the 50% that if, the younger populations, if they live healthier lives, they start saving more, they buy, they look at, is insurance to at least cover some of the gap important? I really think we need to do that, so that ultimately, I think this is one of the problems with the Class Act. If there is no managed care, no bending of the curve, no improvement in people living healthier lives, so the total cost, whether Jeff's team is taking care of them or Bob, to bring the cost down, the cost for 78 million baby boomers as they age is just too expensive. So all of that is going to be needed. But there's no question that the private sector, while we may add efficiency and innovation and those kinds of things, the private insurance sector, I think through hybrid and some of these new products can cover some more of the cost. But in the end, we are going to have to significantly expand, whether it's, as I say, Medicare, Medicaid, or other social programs, to help the people who are already getting up there in age, are not too far away from, being in the peak years where they'll have these diseases, and they just don't have the financial capacity. So something has to come forward from Congress, and there are a number of people in Congress. Got Toomey has bills, and Susan Collins and others, but a lot of work to be done.
Yeah, there's more activity. There's also in the states, as we mentioned, many states are starting to think about it and how to work together. The states have a lot to lose on the Medicaid program when people do spend down, the feds too, but they're more hyper-focused because they have to balance their budgets. And, I think we'll see some innovations there as well. So we knew this time would fly, went by so fast. So I'm going to give each of you like a 1 minute, one word, or just a sentence on what you want to leave the listeners with when they think about the future of long-term care delivery and financing. Jeff.
I think Tom and Bob made great points. I guess I would like to see, we've got a proud history in this country of using tax and fiscal policy to incent behaviors. If we want to incentivize home ownership, we make the mortgage interest deductible. If we want to incentivize college savings, we create the 529 account. I think there's a lot that can be done with tax and fiscal policy to make policies or services like homesteads or facilities like Bob's more affordable and allow us to save. We're going to have the private sector individuals step up. We're $25 trillion in debt right now, growing exponentially, and 80 million baby boomers so we're going to have to come up with some creative solutions.
Great. Bob, 1 minute.
Preventative care is often not talked about, and preventative care is really important so that people don't end up in a position where they're unhealthy and need the more extreme care that's often available. I would definitely orient more resources towards preventative care. I think that modifying Medicare and Medicaid in a way, maybe coupled with a private initiative to help make managed care more affordable to somebody who's worked their whole life to supplement Social Security, would go a long way towards removing that uncertainty for people who are in need of more intensive care as well.
Absolutely. Tom.
I agree with my colleagues. I would say, I think Americans are more and more focused that climate change is a big challenge for us. I would say an equally big challenge with the oldest baby boomer now 74, 6 years away from 80, peak years of long-term care disabilities, that for Americans, treating with respect these 78 million baby boomers as they age, because they're going to start turning, you gave the statistics on turning 65. In 6 years, they're all going to be starting to turn 80, and that will go on for another 20 years. And we don't have a public or a private system that can deal with that so that they can live high quality of life and in respect. And so I think it's as big or bigger issue. They're both big, climate change, and people are focused on that. But this dealing with our aging populations who, for whatever reason, they are where they are, but they can't cover themselves for all these costs. We got to figure out a way to do it. And more organizations like Bob and Jeff and maybe the insurance industry can help to work with the public sector and Milken Institute to really not just talk about the ideas, but it's getting too late to talk, and we really do have to come up with
Exactly.
solutions.
We've been talking for a long time. We're ready to start moving. So you're preaching to the choir here, but I hope that we reached out to some people that weren't part of our singing group today. I do want to thank you all for this wonderful conversation. We're not done at the Milken Institute. We're embarking on the second phase of this research, where we really want to have some virtual labs where we bring people together to move this change forward. I encourage any of our listeners who are interested in joining us in this effort to just reach out to us and check out our long-term care page on the Milken Institute website. We really appreciate you being with us today. It was a great session, and we'll look forward to the rest of the summer series.
Thank you very much, Nora.